Hi, everyone. I'm Beth Johnston. I'm the Chief Community Engagement Officer here at the FSHD Society. And together here with Ms. June Kinoshita, our Director of Research and Patient Engagement, we'd like to welcome you to a brand new year of FSHD University webinars. Woo, 2022. For those of you who don't know us, the FSHD Society is the world's largest research-focused patient advocacy organization. That is a mouthful. That is focused solely on FSHD. We have now 33 chapters across the US and in Canada, and we're part of the 19-country World FSHD Alliance. Our mission is to find treatments and a cure for FSHD while empowering our families. And today, from our physical health department, we welcome physiotherapist and PhD candidate Jos Ijspeert. How did I do? Jos Ijspeert from Radboud University Medical Center. He's in the Netherlands. Jos has been doing research on the potential for exercises to improve shoulder dyskinesia, which can result in the scapular winging that many of patients with FSHD experience. But June, would you like to properly introduce Jos?
Well, you've covered a lot of it already, but I think Jos is a practicing physiotherapist. So he works with FSHD patients at Radboud. And he is also a PhD candidate doing research on the impact of different types of physical therapy for issues that FSHD patients have. So he'll be sharing that work with us today. I actually heard him present for the first time in Marseille at our International Research Congress. Is it almost 3 years ago? It's hard to believe. And I remember making a mental note to myself, like, we have to share this information more widely with patients. So really excited to have that opportunity to do that today. I wanted to note that Radboud is really, I'd say, one of the world's leading centers for this type of research on FSHD, clinical research under Basile van Engelen and now Nicole Formans, who we work with closely. And we're really happy to kind of be deepening our relationship with Radboud, because there is so much going on there that often doesn't percolate across the ocean to change practice here, and we think it should. So that's part of our mission here, to make sure that wherever there is great research going on in FSHD that can be beneficial to patients anywhere in the world, that we are the place that can present it to you. So with that, I'd like to turn it over to Jos.
Thanks, June and Beth, for the nice words and kind introduction. And thank you all for joining this, well, I think, important topic for FSHD. And as you see in my title, I think therapy in general shouldn't be just physical therapy. It's just all kinds of therapy could be helpful in FSHD. And I'm thinking that maybe we shouldn't focus that much on weakness, but maybe we should emphasize more the coordination of the shoulder girdle, and then maybe we can help patients more. The strange thing about FSHD is that scapular instability, it's in the name of FSHD, so facioscapulohumeral dystrophy, and 96.9% of patients experience problems when using shoulders and arms. But most exercise interventions that have been researched target lower extremity function. So there seems to be a lack of knowledge there. So a lot of problems that patients or persons with FSHD experience aren't really researched. What we also know, at least for the legs, is that in FSHD, exercise more or less equals medicine. So on the right side, you see a figure of a study of Janssen et al. In 2016, and they looked at the effects of aerobic exercise for the leg muscles. And they checked the leg muscles for the change in fat fraction per year. So how much fatty infiltration in the muscle because of muscle damage through FSHD is occurring in these patients. And then you can see that more or less 7% of the upper leg muscles are wasted during a year's time, so more or less. And in two exercise groups that move more, it's more or less 2.6, maybe 1.8%. So if you move enough, you'll probably protect your muscles at least by 2/3 in the progression of the disease. But only 44.4% of patients seem to exercise the upper extremities. So there's a world to be gained if we just at least include our upper extremities in our training interventions, I think. In FSHD, scapular movement is usually difficult. Normal scapular movement, there's a lot of discussion about what's normal scapular movement, but it could look somewhat like something like this. And now my animation doesn't work, but the scapula should move underneath the arm when the arm moves to flexion. So when the arm moves upward, the scapula moves to the axilla region, and it positions itself underneath the arm. So this is a typical FSHD patient with a lot of loss of muscle strength for the scapular stabilizing muscles. She has bilateral winging scapula, as we call it. So the scapulas protract from the ribs. They form like a winging sign, and there's almost no scapular support for the arms. The name FSHD is there's humeral in FSHD, and although humeral is in the name, the humeral muscles are usually not that weak. So the deltoids, for instance, are quite strong, and they are usually hypertrophic because they work they pull on a scapula that's unstable. So they have to work really hard all the time to get the arm to move anywhere. So there's low muscle strength of the scapular muscles, but there's quite normal strength of the arm muscles and the scapular braces that brace the scapula in a forward tilting motion, which causes the winging. If we look at the ideas that we formed over the years about coordinational therapy for shoulder instability, we can look at another disease that's called Parsonage-Turner syndrome or neuralgic amyotrophy, which is a nerve inflammation disease, which also causes scapular instability, but usually more unilateral. And this is a guy that is 22 years old, and he has had this since he was 16, so more or less six years long. And the interesting part of this is that after 6 years, you don't expect any nerve recovery anymore. So the nerve recovery that could have been completed has already been completed in 6 years' time. But if we start therapy at the left point and we go to the right in 6 months' time, then you can see that he can move a lot better, a lot more relaxed, and with a lot less pain. So the idea that we got is that scapula lata, or winging scapula, or tipping scapula, can be caused by dyskinesia. So movement problems, coordinational movement problems, and not so much through weakness, muscle weakness. And I think that's one of the big PR problems of FSHD. So everybody that sees an FSHD patient, at least there's a lot of clinicians already think if they see a winging scapula, the scapular muscles are wasted there. They are not strong enough. But I'm thinking that that's not the case always. If we look at the scapular muscles, and I kept this slide in, so if you want to talk with your physical therapist about which muscles do what, please use these slides. But there are a couple of muscles that are in the on the medial side, on the inner side of the scapula. So I'm using the laser pointer now. Can you see this, June? Yeah. So the medial scapular muscles that pull the scapula towards the spine, they are usually quite active. And they like to work together. So the major rhomboids, the minor rhomboids, the levator muscle, these three muscles like to work together with the minor pectoral muscle. And then you get the position, the posture that you saw in the patient that we started out with. The scapula moves inward and rotates downwards. So the glenoid, so the shoulder itself, rotates downwards, and the scapula tilts away from the ribs, because the minor pectoral muscle pulls it to the ribs in front, and on the back side, the scapula pulls away from the ribs. If we look at the scapular muscles, there's a really big stabilizer that can pivot the scapula towards the to the axilla region, so move the scapula underneath the arm, and that's the serratus anterior muscle. The serratus anterior is a lot stronger than the smaller muscles on the medial side of the scapula. So if we use the serratus anterior, we'll be able to produce more strength over a longer period of time. Eventually, if we go back to this patient, eventually this patient will have scapular instability, and the serratus anterior muscle will be fatty infiltrated and will be really weak. So she's beyond scapular training, sadly. But there are a lot of cases that I think are not beyond training, and they should train the scapular muscles to preserve the strength. If you look at the scapula as a bone and you build in like working lines for the muscles, then you could divide the muscles up into two groups. You have a couple of muscles that are used to brace the scapula against impact, I always say. So if you walk against somebody in the subway, you tilt your shoulder forward a bit, you press your arm against your body, and you brace yourself for impact. But that's not the most convenient position to use your arm in, because it also limits a lot of movement, and it's really ineffective in the way you use the strength that you have. If you want to move the arm, it's a lot more easy if you position your scapula posterior tilt, a bit backward, and then use your arm in front of wherever you want to move. And the consequence of maintaining a scapular posture in bracing position is that the smaller muscles that I before mentioned that do that get irritated, they get overloaded. And so there's a lot of muscle pain, a lot of cervical pain in a lot of patients with NA, because they use the levator muscles way too much. What they do is they overload the muscle, but they also overload the upper cervical region. Normally, if you use the serratus anterior muscle, the bigger one that goes to the side, to the ribs, then you can spread out the load that your arm produces over a really big surface area. But now you spread out the load over just 1 to 4 cervical vertebrae. So a lot of patients also have neck problems, costovertebral problems, and sternal problems, because they use the pectoral muscles a lot. As well, a big issue in a lot of FSHD patients are impingement problems, subacromial impingement problems. So if you look at the left shoulder, this is an image of a left shoulder. This is the humerus, so the arm. This is the scapula, and this is the clavicle with the acromion. In between of the acromion and the humerus, there are a lot of cuff insertions, so some tendons, and there's a bursa. How do you call that in English? June, can you help me out?
A bursa is also the term in English.
That's the term, yeah. So if your scapula is unstable and it tends to move forward all the time, when your arm moves upwards, the space between the acromion and the humeral head gets narrowed. And if that happens too much, the tendons can get inflamed and they can get thicker, and the space gets even more narrow. So a lot of patients that have FSHD have a more or less constant irritation of cuff insertions. So insertions of the tendons that are attached to the humeral head. And the third problem patients can have but don't have all the time are entrapment neuropathies. So the nerves that need to go to your arm from your cervical vertebrae, they pass some like gates of muscles, and they can get trapped in high tone cervical muscles or high tone pectoral muscles, and then you can get radiation complaints in your arm. So tingling sensations, numbing sensations, but also sometimes sensations that are described as thoracic outlet syndrome. And they can be mild to really severe, and in some patients, it's a reason to do really big surgery to remove a rib to give some more room to the nerves, because they can get really big complaints and really big problems in the endurance that their arm has in using their arm in specific positions. So what we think that can be achieved for muscles targeted by FSHD in the shoulder girdle, it lies in a couple of attributes that you need for movement. And I think you need 4 attributes for movement. You need some joint flexibility, you need a measure of strength to do movement, you need some endurance, and you need some technique. And what we seem to think about scapular training is that especially endurance and movement technique are the factors that are influenceable. So the strength is something that you can train, but FSHD muscles not also always respond to strength training that well, and doing strength training in like low repetitions, high strength setting is really not advised, because you could also damage the muscle. We know that more endurance like training is safe for the muscle. I've already shown you that for the upper leg muscles, it means that you can protect the muscle against dystrophy, but the really high intensity training might not be the best way forward. But it hasn't been extensively researched. But endurance is at least it's safe, endurance training, and technique training is like low-hanging fruit, I think. So you don't need to get stronger, you don't need to get fitter, you just need to get more precise in your movement. So what you can do if you see an FSHD patient and you see scapular instability, it's good to try and differentiate for muscle strength problems or coordinational problems. So here we have a patient that has, he's 38 years old and he has genetically confirmed FSHD, and he has a lot of scapular instability. And that really limits his arm in movement above his head. So he can't do that. And that's one of his questions. And if you look at him, it's really easy to think that the serratus muscle, which should pull his scapula towards his ribs, isn't doing anything, and it must be weak. But you would be mistaken, because if you challenge him to do it in a certain angle in which he is not able to use a lot of different muscles than the serratus, then the serratus will become active. Here it isn't. But if I ask him to do it from his elbow, which is we think it is a more selective movement, I can really produce strength. Maybe it's not that well visible, but so if we use the extended arm, I can press his scapula away from the ribs, and I can derotate his scapula more or less. But if we use the elbow test, then you can see that he produces a lot more strength, and I need to work a lot harder, and the scapula stays on the ribs. So the serratus muscle actually has strength, but he just isn't recruiting the strength that he has in the movement that he's doing. So it's more of a coordinational problem than a strength problem. So what we're used to doing is a couple of explicit scapular training exercises, which help people learn how to position the scapula while using their arm. So the scapular tilt that you need is quite small. It's a subtle movement that should be maintainable during the day. So it shouldn't be hard work, and you should be able to move your arm more or less to 70, 80, 90 degrees without a lot of work being done by your scapula. Your scapula should just maintain position. So you start out in the lower range of motion. You help patients by placing them in supine position, feeling where their scapula is, sometimes using their hand to palpate the position of the shoulder, and then you move the arm without all those compensating movements of the shoulder. If they can do that, you can also try that seated. So if the scapula tilts forward, you correct it, and then you move upwards to a cabinet or to a bookshelf or whatever, and you try to envision the movement, carry out the movement, and correct if the scapula goes outwards again. And if you talk about coordinational change, it's good to know that our brain, our cortical part of the brain doesn't really program movement as movement, but more as tasks. So these are quite clinical movements, but it's also good to just incorporate daily tasks like brushing your teeth, drinking coffee, doing laundry, hanging up laundry, all kinds of stuff that people encounter in their daily life, because that will dramatically increase the hours that you exercise without increasing the load in an already overloaded shoulder. Sometimes you can also provoke scapular movement by helping people get out of a movement pattern that they always use. So this is also an FSHD patient. On the right, you see her with a movement trick, and people that are doing shoulder therapy, they'll recognize it. So on the right side, you see that she's using a movement trick on which she gives some pre-tension on the exorotators of the shoulder, which helps her get out of the position where the shoulder tends to move forward all the time. And if I provoke that, the range of motion increases from like 90 degrees, maybe 100, to a lot more. And now the presentation doesn't really work, but maybe even 150, 60, 70 degrees. And she's not really pulling up her arm with the other arm, but she's using the cortical information that she's using on the left side to help assist the right side. If we look at children, then I think they might be the prime candidates for therapy addressing scapular posture. This is a child that we have seen in our pediatric shoulder clinic, and she has also FSHD. And this is, I think, the third or fourth consultation. I didn't have a big starting video of her, but she could reach about 110 degrees of flexion, and now she has improved a lot. And the way we train children obviously is a lot different than adults. So the explicit way of training that you saw before isn't really appealing to kids, but it's also not really the way to go, in a sense that they cannot do it that way. You can still see some scapular instability on her right scapula. So when she moves her right arm down, the inferior angle of the scapula, so the point of the scapula, moves out a bit. But it's a lot better than it was before. And that's because our pediatric physical therapist, Maaike, has taught her how to move more relaxed in a more posterior tilt manner. And she's used all kinds of playful exercises to do that. And in implicit motor learning, you can do whatever you want when it produces the scapular position that you need. So you can use balance reactions, and you use a balloon to give her some time to react, but you try to get her to move away from the body with the arm, because when she moves against the body, the scapula tends to become unstable again. And she needs a balance reaction to move her arm also in a relaxed and normal fashion, without all the attributed motor control, I think, faults that she has learned during the years, because her arms are getting heavier. And these tools are really nice because they are, so I've disabled sound now, but they're like hollow tubes that produce sound if you swing them around really hard. So you can see that she has fun doing it. And Maaike is asking her to move her arms higher and higher, and in a playful manner, without she really realizing what she's doing movements that, well, she thought she couldn't do before. There it is. And you can tell that we're trying to give her like a supinating movement in more or less exorotation away from the body. And that usually helps to do stuff like that. But you can also use the favorite sport of somebody and just try to emphasize the movement in the way that you see fit and that you see the best scapular results in. So for instance, if you have a kid that wants to play basketball, you might consider using a bit smaller ball, but you could try and have him throw the ball in like the lateral position more instead of in front. And if the lateral position is better, and it's maybe even better if you're standing on one leg because you're using the balance reaction and the extension of the cervical and thoracic vertebrae, then you can progress to like normal movement in the daily sense. So the idea that we have is that scapular dyscoordination, dyskinesia of dyskinesis, produces disuse of the scapular muscles in daily activities, and mainly in the muscles that would stabilize the scapula but aren't now. That might accelerate the fatty infiltration. If you think back to the training effects in the upper legs, if that's the case in the shoulder muscles, then the muscles you don't use as much will be accelerated in fatty infiltration. That in turn will produce muscle weakness and also increase limitations in daily life. What we're hoping is that therapy can produce an escape for these patients. So maybe if we use scapular coordination training, we'll have less disuse and limitations, and maybe even slow down fatty infiltration for the shoulder muscles as well. So the take-home message is that scapular coordination might be more influential in arm movement restrictions than loss of muscle strength in part of the FSHD population. And I think mainly in the younger patients that don't have really progressive FSHD yet. So normal move of the scapular muscles might protect from rapid progression of the FSHD. I always tell my patients, arm movement is really hard to restrict. So you can sit down in a chair and don't move your legs as much, but you're always using your arms all through the day. If my patients ask how much their arms move, I'll just give them a raw figure, but it could be more or less 5 times a minute, and that would correspond to 4,800 movements a day. So if we do 4,800 arm movements with adequate scapular posture, the scapular muscles will be protected, I think. However, what we know from clinical experience now is that scapular coordination is a bit more difficult to influence in FSHD than it seems to be in neuralgic amyotrophy or the partial Turner problem. We're not really sure why that is the case, but I'm hypothesizing that it might be due to loss of sensory function in the muscle over motor function. So our muscles are not only organs that move our arms or move our legs, but they also are organs that tell our brain what the position of our shoulder and arm in space is. And if the muscle gets wasted, I think also some of the sensory function of the muscle is wasted, and it makes it a lot harder for the brain to make an accurate estimation of the scapular and arm position during an activity. So for some patients, it's really hard to learn this, and it can be a frustrating process, which all motor learning can be. But in FSHD, that might be something that you encounter, but it's still always worth a shot. We do this work here in a team. Nicole Voet and Jan Groothuis are our physiatrists. Nicole Voermans is one of our neurologists, and Basile van Engelen is the head neurologist of our neuromuscular team. And Maaike Pelsma also deserves a special recommendation because she's the pediatric physical therapist who is a lot better than I am in implicit motor learning. So I would encourage all physical therapists, but also patients, to also include pediatric physical therapy, even when you're not a child, to just get creative in the way you exercise. Hilde Braakman and Corrie Erasmus are the pediatric neurologists in our center, and Corrie is leading in the FSHD research. So without them, we couldn't do what we're doing now. So I just wanted to mention them. So I think I kept it more or less on time. Hopefully it was a clear message. Thanks for your attention, and maybe we can have some time for questions now.
Thank you so much. That was really interesting. And and we have a lot of questions. So why don't we jump in? I think one question is, can you show some of the physical therapy methods to strengthen the scapula area? So I think maybe that's a topic for a new video or a Zoom session down the line.
Well, I've shown some, but I think strengthening is not the way you should look at it. So you're looking at coordinational deficient, not strength deficient. So what you're trying to do is improve the scapular movement in all daily activities. And what I do usually is we start out with smaller exercises, but if scapular posture improves during the exercises, then we try to implement that in daily living. So brushing your teeth can be an exercise. Drinking coffee can be an exercise. And if you focus on that for a week or 2 or 3, you could improve scapular posture during those activities. And the nice thing is that patients that do that, that they come back to me and they say, well, I've really focused on those 3 movements that we've used as an exercise, but I've also identified a couple of other movements that are not that great. Could we look at them? And the idea is that those 4,800 movements during the day, they have a great potential for training if you do them correctly. And if you just take half an hour twice a week with your physical therapist to do exercises, that stands in no comparison to what you're doing on a daily basis. So I'm thinking that if you want to do adequate physical therapy or therapy in a broader sense for shoulder problems, you should always incorporate daily activities, and the focus should lie on coordination over strength. And the other problem is that if you're like weak in coordination and you use a lot of strength, the coordination deficit becomes more visible, so it becomes even stronger. So a lot of patients that have scapular dyskinesia and they do a lot of strength training, the scapular dyskinesia will already be there, and it will increase because you're loading the scapula with strength in the position that isn't adequate. So you're only feeding the muscles that are already doing too much.
That's a lot to think about. That's good. I think in your video, you showed some of these movement coordination exercises. They're very subtle, I think, and probably people would need some guidance from a physical therapist to make sure they're doing it correctly.
Yeah, I have a course for physical therapists, and I've been giving that for like 8 years now for Parkinson's Turner and neuralgic amyotrophy. And they almost all my colleagues say, well, it's just so little that you give them. But it's about doing little things all day long.
There's a question here. Someone wanted to know what is the deltoid? So
the deltoid is a big muscle on the on top of the humerus. That is the main muscle that positions your arm into space. So if the deltoid doesn't work, you'll be able to lift up your arm just a couple of centimeters.
Right. And another muscle you mentioned quite a lot is the serratus anterior.
Yeah.
How does where is that on the body?
Wait a sec. I'll just go back into the present. There it is. So on the rotating skinny guy, on the right, you see the red serratus anterior muscle. So the serratus anterior is the biggest scapular muscle. It's the biggest shoulder muscle, period. It's really strong. So in muscle testing, we use the terms make or break testing. And if you do a muscle test and you can break the muscle strength, you can push through the muscle. A normal serratus anterior isn't breakable. I'm a big guy. I'm about 115 kgs, but I can't break a muscle strength of a 60 or 120 pound or 60 kg woman. So normally the serratus anterior muscle is really strong in a lot of FSHD patients, the muscle is getting weaker, but I think that in a lot of FSHD patients, there's still a lot of muscle strength to work with.
Mm-hmm. Great, thank you.
But this is the serratus muscle, the one on the right.
Great, thank you so much. There's a question, how can this impingement, the entrapment, be diagnosed?
There are different ways. There are a couple of clinical tests. And in diagnostics, we always talk about specificity and sensitivity of testing. And the diagnostic clinical tests aren't that great in specificity or sensitivity. So they're not really good at accurately finding or ruling out the diagnosis. But the clinical picture is quite clear. So a lot of patients that have impingement problems, they have pain in the upper arm region. So more or less in the point of the deltoid region, or more a bit in front of the shoulder, or more a bit in the back of the upper arm. The pain can also be located in the acromial region. They usually have some tenderness in the insertions of the tendon there, but not always. And they have a sign that's called a painful arc. And a painful arc is when you move your arm upwards, that you have an area like maybe in 120 and 140 degrees, that's painful. And if you move through that, the humeral head moves under the acromion and the tendon isn't impinged anymore, and then the pain goes away. And if you go back down, it's there again. And if you further down, then it goes away again. You can also do ultrasound examination of the shoulder to look for inflamed tendons, to look for thickened bursae. And you can do MRIs or other diagnostic research, which is usually done by an orthopedic surgeon if it comes to that. But sometimes, I think in America, you have the doctors of physical therapy that can do like imaging as well. And you can do imaging to objectify the diagnosis. But usually the clinical image is that clear, and that you really don't always have use for imaging. And the way you should tackle it, I think, is by trying to treat the scapular instability, at least in FSHD. But I'm thinking that in a lot of other shoulder patients with impingement problems, the scapular problems are also the cause of the impingement problems.
Thank you. There's a question you had mentioned about high intensity training not being advisable in FSHD. Are there published studies about this?
No, well, we know that low intensity training is safe, and there has been quite a lot of research into aerobic exercise, so low intensity training for FSHD, and that's not for nothing. So the ethical considerations when setting up a training study, they require that we do not harm the patients that we want to research. And the way training effects are built up in aerobic exercise, so low intensity, long duration, is that there's a lot less, production of waste materials in the muscles. And if you do high intensity training, you're producing a lot more lactates and other waste materials that build up in the muscle, and they damage the muscle over time. So it could be that those trainings are damaging for the muscle. At least they will be on the short period, and we're a bit cautious because we're not really sure how good FSHD muscles can respond to that. So normal healthy muscles, they can improve quite well by clearing out the waste in the muscle, and then repairing the muscle tissue that got damaged and making it even stronger than it was before. But FSHD muscles might not be able to do that as well. So be careful when doing high intensity training.
Okay, thank you so much. There's a question, can one draw a parallel between the shoulder girdle and the hip girdle in terms of, I guess, the dyskinesia issues?
Oh yeah, I think that's why we use like the balance aspect in training. So in the 12-year-old girl you saw with FSHD, we used balance reaction to improve scapular posture. So if your pelvis moves a bit to anterior tilt, your spine will extend a bit more, and it will be easier to position your scapula because the shape of your ribs is a bit flatter. But also you'll be prone to do that because you're in like an extension mode. And the scapula in FSHD wants to go to flexion. So if we help patients get to extension, that'll help. So you can also use all kinds of ways to provoke that in like pelvic position, knee or foot position. And if patients get older, that gets more difficult because usually the abdominal muscles get weak as well. So the amount of support that they can provide for their lumbar and thoracic region is decreased. So they usually get decline in posture of their spine, which also makes it more difficult for the scapula to stabilize. So at least in younger patients, it's really good to incorporate that in training.
Thank you so much. I'm wondering if the questioner might also have in mind that hip girdle weakness, I guess if you call it, many patients have difficulty getting up from a sitting position.
Yeah.
And if that is also perhaps not just a matter of weakness, but of discoordination. Do you have any thought about that?
Well, I think some of the patients have, well, it's undeniably a problem that a lot of the at least lumbar extensors get affected by FSHD, and they show fatty infiltration. And if they're really wasted, then there's not a lot you can do in strength perspective, But there's also a coordinational theme in lower back problems that you can use for therapy, and then you have to focus on like the, how do you call it, how the primary stabilizers in the lumbar region and the secondary stabilizers work together. So in the lumbar region, we have a couple of deeper muscles, our pelvic floor, our diaphragm, and the deeper abdominal muscles that function as primary stabilizers. And then we have a couple of superficial muscles that are really strong that function as, well, movers. And in a lot of patients where there's some weakness, the primary stabilizers don't do that much. So if you see that, it's a coordinational deficient, and you can also try and improve the coordination. And that's why I talked about coordinational training in scapular problems as low-hanging fruit, because for coordinational benefits, you don't have to get stronger, you just have to get smarter in movement. And I think maybe in the lower back that will also be the case, but there's even less evidence for that than there's in scapular movement.
Well, a good topic for future research, perhaps. All right. There's a question, you referred earlier to the study showing that you can limit the amount of fatty infiltration in the leg muscles through exercise. Is there any evidence that this can actually improve muscle strength? Are you just preventing?
We think it can maintain muscle strength. So it's not as much as focused on improvement as it is on maintaining of the muscle strength. So what I always say to my patients in FSHD, if you don't decrease in muscle strength, you're improving your life. You don't have to get stronger, you just have to stay strong as much as you can. And that's the idea. And I think maybe also by the good work you're doing at the FSHD Society, if there will be a medicine, a pill developed that can help decrease muscle infiltration of FSHD, and then it might be possible to get stronger even. So it would be really good if the trials that are done in a medical sense, in pharmaceutical sense, would be combined with training exercises to check if the patients that get help from a pharmaceutical perspective are also more trainable. Maybe they are. But now, I think the goal should be to preserve and maintain strength, not so much increase.
Attendee here says, some physical therapists have explained to me that scapular winging is caused by an elongation of some back muscles, which prevents these muscles from fully contracting to pull the scapula towards the ribs. Is that true? And how does that fit into the picture of the scapular dyskinesia that you've been describing?
I'm not sure about elongation. Well, the thing is, I think the scapular muscles that should be able to position the scapula on the ribs correctly, they get weak in FSHD. When they get weak, they get infiltrated by fat, and fat doesn't contract, so the muscle will get a bit longer. If that's what they mean, I think they're right. But I think the back muscles are not that affected or not that influential in the scapular posture unless they get really weak. And we talked about that when the back posture gets that terrible that the scapula even gets more unstable. But I think in a lot of FSHD patients, it's mainly the scapular muscles that we talked about before that are a reason for concern.
Okay. I have to say many questions from people saying, can you share some exercises that they can do? Yeah. So we will.
The difficult thing about sharing exercises is that, well, an aerobic exercise program is quite easy to make a protocol of. If you do like coordinational exercises, everybody learns a bit different. It would be really good to just look for a therapist that will try out stuff with you and try the things that would work. I can share a couple of like standard exercises that work for a proportion of the patients, but not for all. And you need to be willing to just do trial and error. And everything that works in a way of balance reaction, in a way of feedback of posture by placing your scapula against the wall or lying on it, or maybe I didn't mention that, but maybe you use a visual feedback by mirrors or whatever. Everything that works is okay with me. But you just need to constantly check for adequate scapular movement and then follow the path that your patient shows you.
So kind of related to that, you mentioned even small daily tasks like brushing your teeth or lifting a cup of coffee, that I guess there's a correct way to do that stabilizes. And can you describe that a little bit more possibly?
Yeah, well, if a lot of patients that have shoulder problems, they use their shoulder while brushing their teeth or drinking coffee. So I'll just get a glass. So they won't drink like this with their shoulder more or less in neutral posture, but they will drink like this or this, which is a lot more strenuous. So if you want to improve scapular posture by when you're drinking coffee or water or whatever, you just have to position your scapula in posterior tilt. That'll activate your serratus anterior. So you're tilting your scapula backwards against like the backrest of your chair, or maybe against the wall to feel it a bit better, or maybe use a mirror to see what you're doing. And then you try and maintain scapular posture while moving your arm forward. And if you're not able to do this, you do it in a lower range of motion first. And then you gradually increase to higher ranges of motion. And the same goes for brushing your teeth. most people brush their teeth in front of a mirror. And you can check your scapular posture in the mirror because your scapula is attached to your acromion, which is in front. So if your shoulder is unstable, you'll lose acromion height. So you just take a piece of lipstick, you put a marker on your mirror where your acromion is when you start out brushing your teeth, and halfway you just check if your acromion is still on the same height. If you're maintaining posture, you're training scapular positioning.
Right. So we have several questions here about scapular fixation surgery.
Yeah.
So
well, I'm
when is that appropriate?
Not an expert on that.
Okay.
But I can share some thoughts. We have one of our patients has gone to a Turkish surgery group that has done a lot of scapular fixation surgery in FSHD patients, and they published quite good results. In the Netherlands, it's not really a big course of action that is advised, but maybe that'll change in the future. We're not sure. The fixation surgery promises that you'll get a lot of range of motion by stabilizing the scapula against the thoracic wall, and therefore creating like a stable foundation, more or less, for your arm to move in. The problem is that it's non-reversible. So if it doesn't work, yeah, you can't really release the scapula again, because they usually use steel wires that go through the scapula and through the ribs, and they how do you call it? They consolidate with the bone, so the scapula more or less grows tight onto the ribs. So if you do those kinds of procedures, it's not really feasible to release the scapula again if pain gets a problem or the movement isn't as good as you would have expected. So we're a bit cautious in advising that, but maybe the future will learn us that it can be a good way for the patients that have at least lost a lot of muscle strength. Mm-hmm. So the woman you saw with the longer hair that couldn't move her arm past 90 degrees or something like that, she didn't seem to have a lot of muscle strength, but when you emphasize the muscle strength in the right way, it's there. So she isn't a candidate. But if you cannot, and the serratus muscle is really fatty and it's really weak, yeah, then it might be an option for some. But I'm not sure exactly which people could or could not benefit now.
Right, okay. Some more questions about specific types of exercises. So several people have been talking about yoga being very helpful, and a specific question about the plank position or downward dog yoga positions. Are those good ways to exercise?
But you can do those exercises in like a maladaptive way and an adaptive way.
Okay.
So you can use your pectoral muscles a lot to stabilize your scapula when you do planking exercises. Okay. Possibly the side plank would be better, but it's really tough because you're asking a lot of the serratus muscle. Mm-hmm. But in the side plank, you won't be able to use the pectoral muscle as much. Mm-hmm. You can also do movement kinds of movement that is used in a Tai Chi or a Qigong or movement like that, because those are also movements that really emphasize on selective use of your body. So the idea is that FSHD patients usually don't use their arm as much. They use their whole shoulder girdle to move and position things. What you want them to use their arm a bit more and stabilize the shoulder girdle. And movements like used in Tai Chi or Qigong are usually focused on that as well. So those can be effective, I think, for some of our patients, and some of our patients also do those.
We also, a lot of patients like to do exercise in the water or swim, and they find that beneficial. Are there particular types of swimming motions or exercise that would be beneficial for?
Swimming can be really helpful because the water can help you like support your arm a bit and make movement possible that you're not that you won't be able to do in like normal gravity situations. So swimming can be really okay, but for some patients it's just too much of hard work. There's a technique that's called immersion swimming. That's like how do you call it, a chest crawl position. Is that the correct term? I'm not sure, but like the normal swimming movement, but then you extend your arms a bit less and you keep them to your body a bit more, and you try to propulse a bit more with your legs instead of with your arms. So if swimming gets too tough, maybe immersion swimming is something that can still enable you to swim and use the scapular and arm muscles in an aerobic fashion to protect them, but make it a bit more easy.
Okay, there's a question about whether one could use an upper body brace, I think, to maybe stabilize the scapula while doing the exercises. Have you looked at that?
Tried a couple, but we didn't really, we weren't really pleased with the results. And the big problem is that the amount of strength that you need to stabilize the scapula, I talked about serratus being really strong and being so strong that I won't be able to break the muscle strength. Well, that's more or less the strength that you need to produce on the scapula to keep it in position. So there's I think a Danish group that has a course for orthopedic, how do you call that in English? For people that produce braces, and they produce like a Roman cuirass, more or less, that's around your shoulder blade, around your scapula, and keeps it in position. But the patients that I know that have tried that found that really uncomfortable. So it keeps the scapula in position, but scapula pulls that hard against, maybe presses that hard against the brace that the position becomes uncomfortable. However, if you use scapular taping, and I can maybe share some slides of that as well. But if you use scapular taping to help give the information that is needed on scapular position and therefore improve coordination, then you don't need a lot of strength. And that can be really helpful. And there's also, I think it's an American brace. It's a company that's called EVS. And they produce motocross braces, and they have developed a shoulder brace that I've adapted for my patients, and that brace is helpful for some patients that have mainly coordinational problems. So the answer is to the bracing is that if you're really weak in your scapular muscles, bracing probably won't help you as much. But if you have enough strength and the coordinational deficient is a problem, then you can try scapular taping and maybe even bracing to help you position the scapula better.
Great, thank you. And we are out of time, unfortunately. I wanted to share a comment from one person in the audience who says he agrees with everything that you're explaining, and that he thinks it can work even when you're older if you're not too impaired and have the ability to practice. Key thing is to be patient. Progress can be very slow, and avoid the use of force until you are sure you're using the right muscles and disengaging the ones that should not be doing the work. I've made major progress in my 60s, in large part doing things very similar to what Jos describes. Coordination is also key and very difficult because the brain does not want to naturally do it, and it needs to be trained.
Yeah, that's also a topic that really needs investigating. So what does FSHD do with our sensory system? And how does it affect the way our brain can recruit our body?
Yeah, so, well, you can see this is an area of intense interest, so many more questions, which I'm afraid we won't have time to respond to today, but we will be posting the video on the FSHD Society YouTube channel. And Jos has kindly offered to provide a handout that we can download. We'll post it as I think a PDF document on our website. I think we'll put it in the FSHD University section. So you'll be able to download that and share that with your physical therapist. And we've also gotten a ton of ideas for future videos and programs we can do in this area, including the physical therapy for children, ways to motivate them, turn it into a game so they actually do the exercises. The course for other physical therapists, I think we'll have our community of physical therapists will be very interested in that. So we will be doing more, I assure you. And thank you all for your questions. Feel free to post more of your questions. Where's the best place to do that? I guess I think you can post them on our calendar event posting maybe, or when we post the YouTube channel, we'll include that in a blog post and you can post questions there and we will forward them to Jos. And so thank you all so much. I'm going to bring back Beth Johnston to make some closing remarks.
Excellent. Wow, that was amazing. Thank you everyone for attending our webinar again today, and very special thank you. Oh my gosh, Jos Ijspeert. I learned a new Dutch word, Ijspeert. It's going to be in all of our language now. We're going to keep that in our vocabulary. Your wealth of knowledge is just amazing and so helpful to our community. So thank you so much for being here, for presenting, and for answering as many questions as you could possibly have done. So thank you, thank you, thank you. Our next FSHD webinar will be in late February. So stay tuned for announcement on who our guest will be and the exact date and time of that. But it's usually about the third or fourth week of February. And then tune in tonight, 9 o'clock Eastern time, for the premiere of our FSHD radio show on either YouTube or Facebook, where our host, Tim Hollenbach, he's going to be talking with our Chief Science Officer, Jamshid Arjamand. But you can always listen to the show at your convenience, wherever you listen to your favorite podcast. Please, as June said, visit our website event calendar for all of the upcoming chapter, wellness, and these educational events. And thank you again for joining us today, and we'll see you next time. Take care, everybody. Bye-bye.